name is Jocelyn Brunel, and my topic research for today is central Pontine myelinolysis. I attend Catholic University Santiago de Guayaquil, and you can also find me on my social media. Definition. Central Pontine myelinolysis is a neurological disorder that most frequently occurs after too rapid medical correction of sodium deficiency, also known as hyponatremia. The rapid rise in sodium concentration is accompanied by the movement of small molecules and pulls water from brain cells. Through a mechanism that is only partly understood, the shift in water and brain molecules leads to the destruction of myelin, which is a substance that surrounds and protects nerve fibers. Nerve cells, neurons, can also be damaged. Certain areas of the brain are particularly susceptible to myelinolysis, especially the part of the brainstem called the pons. Applications in medicine. Treatment. The ideal treatment for myelinolysis is to prevent the disorder by identifying individuals at risk and following careful guidelines for evaluation and correction of hyponatremia. These guidelines aim to safely restore the serum sodium level while protecting the brain. CPM was originally described by Adams and colleagues in 1959. He first detailed the entity in a group of malnourished and alcoholic patients. Further studies and advancements in medicine have shown that CPM most commonly results from the rapid correction of serum sodium in hyponatremic patients. Neurologic complication of alcoholism. The majority of cases occur in alcoholics, suggesting that alcoholism may be contributing to the genesis of central Pontine myelinolysis. Postoperative intensive care management in adults. There is no treatment for CPM, so the goal is prevention. Care must be taken in the ICU to correct the hyponatremia after transplant. Postoperative ICU management. Adult liver transplantations recipients. At Baylor University have set the lower limit of surgically acceptable pre-transplant serum of sodium, which is 128 for patients whose condition is not an emergency. Hyponatremia and hypernatremia risk factors include a change in serum sodium level of more than 12 in 24 hours, correction of serum sodium level to a hypernatremic range, alcoholism, malnutrition, and liver disease. Neuropsychiatric complications. CPM is a severe neuropsychiatric complication of liver transplantation. The incidence after liver transplantation is 5% to 10%. The clinical presentations can be real different. In some cases, it can be asymptomatic or silent. Extrapontine lesions. Extrapontine lesions can occur in the basal ganglia, internal capsule, lateral geniculate body, and cortex. Symptoms include motor abnormalities that can progress to quadriplegia, paralysis, mental status changes, and coma. Central Pontine myelinolysis is often fatal in 3 to 5 weeks. Of the patients who survive, many have significant residual deficits. Alterations in the white matter are best visualized by MRI. Pros and cons. Pros. As most patients with hyponatremia do not develop CPM, although some patients with relative mild osmotic insults do, it has been suggested that there must be other predisposing factors. Owing to specific therapeutic approaches, the prognosis of CPM may be improving. Cons. Generally, outcomes of CPEM after liver transplantation have been reported to be poor. CPM may be associated with Marchieva-Bagnami syndrome, which is a rare disease of the corpus callosum also occurring in alcoholics. Although classic cases are purely demyelinating, severe cases may demonstrate significant destruction and cavitation. Issue applied in Ecuador. Report of a case. This is the case of a 21-year-old patient's primary with 1 week pregnancy who attends emergency because of an abnormal gait of 10 days of evolution, accompanied with polydipsia, speech disorders, dysphonia, and vomiting with weight loss of 8 kilos, not compensated by the large amount of liquids consumed during the same period. MRI revealed hypointense lesion symmetric with diffusion restriction in shape of bat wings over the Pontine region, no effective mass or compression of other structures suggestive of osmotic demyelination. All anomalies of the electrolytes were gradually corrected, except for hypokalemia. The patient was able to walk with minimal limb weakness after 5 days of income. The patient was discharged at 25 days after. Conclusions. The first cases were describing patients with a history of alcoholism and malnutrition. However, in subsequent reports, CPN has occurred most frequently in association with rapid correction of hyponatremia. Central Pontine myelinolysis is one of the most feared complications of therapy for hyponatremia. The introduction of MRI made unmodern diagnosis considerably easier, although radiological findings tend to lag behind the clinical picture. The lesions are non-contrasted in casing, and there is no therapy of choice. And finally, a video.
Hi, my name is Jonathan Graff Bradford from the Department of Neurology, and I'll be talking about our upcoming article, Clinical and Radiographic Correlations in Central Pontine Myelinolysis. It will be published in the November 2011 edition of Mayo Clinic Proceedings. Our paper was a retrospective case series of 24 patients with central Pontine myelinolysis that were seen at Mayo Clinic in Rochester. Our objective was to determine what clinical and radiographic findings would help determine outcome in these patients. The main finding of our article is that the volume of T2 signal abnormality on brain MRI does not predict outcome in central Pontine myelinolysis. Additionally, serial imaging is often needed in patients with central Pontine myelinolysis because the initial MRI was normal in a substantial portion of our patients. Lastly, while early reports emphasize universally poor outcome in patients with central Pontine myelinolysis, more recent studies have found this is not inevitable. This is consistent with our data where 60% of patients had a favorable outcome. Physicians are often asked to give a prognosis in patients with central Pontine myelinolysis because the presentation can be quite catastrophic. The next step for this line of research would be to determine what factors and characteristics do determine outcome in central Pontine myelinolysis. The takeaway message of this paper is that in patients with central Pontine myelinolysis, brain MRI should not be used when making prognosis. This is important for physicians who take care of patients with central Pontine myelinolysis because it will help them avoid making a favorable outcome.